Good morning. Good to see everybody awake this morning. Fortunately, we didn't drink too much last night, so even the speakers are awake this morning. So this morning I'm wearing my kidney hat. Yesterday we did endocrinology, so we're going to change things today. As I said yesterday, if you really want to understand what causes diabetes and how to treat it, you need to understand the pathophysiology, and I'll start off by saying the same thing today. If you really want to understand diabetic kidney disease and how we're going to approach it, you need to understand the basic pathophysiology of the disease, and that's the way I'm going to start. And then once you understand what it is that causes diabetic kidney disease, then we'll look at the various therapeutic approaches. And then Dr. Abdul Ghani, who's going to follow me, will go into a little bit more depth about the SGLT2 inhibitors with a focus on the kidney as well as on the heart. So diabetic kidney disease is a huge problem in the United States, just as it is a huge problem here in Turkey and everywhere in the world. We have about 37 million individuals who have diabetic kidney disease, and the shocking thing about this, and this number is true, only 10% are diagnosed, even if you include people with stage 3 kidney disease. Now, stage 3 kidney disease means you have a GFR less than 60. And the real problem is not so much with the fact that people don't check the serum creatinine, but in the United States, because the serum creatinine is part of sort of a general medical chemistry screening, very few doctors in the United States actually check for urine albumin excretion. And so you'll have a lot of people who have a GFR maybe 70, but they can have 3, 4, 5, 600 milligrams of protein in the urine. These people should be treated, but unfortunately they're not picked up. So there has been a huge push in the U.S. To educate primary care doctors that they must check not only the glomerular filtration rate, but also the urine protein excretion. So diabetes is the commonest cause of end-stage kidney disease in the U.S., here in Turkey, and everywhere in the world. And as I said, it's the leading reason why people end up on dialysis or receiving a kidney transplant. And the thing that you need to remember is that even if someone has advanced kidney disease, they are still 5 times more likely to die of a vascular event. So if you have someone with advanced kidney disease, it is absolutely critical that this person has a normal blood pressure. A normal blood pressure for someone with diabetic kidney disease is 120/80. It is not 130/90. And this is agreed upon by all international organizations, including KDIGO. It's a very costly disease. And in fact, if we really pick these people up early enough, end-stage kidney disease should be completely preventable. The problem is we don't screen, we don't get the appropriate test, and even when we get the appropriate test, we don't actually advance the therapy. And as I'll show you, we actually have at least now 4 good therapies that can be used. And if you actually are using these therapies, we should be able to obliterate almost all of diabetic kidney disease. And what is disturbing is, unlike other diabetic complications, both the macrovascular complications, myocardial infarction, and stroke, which have all come down quite dramatically in the last 20 to 30 years, the one thing that has not changed in terms of its prevalence is diabetic kidney disease. In fact, it's going up slightly. So we've made great advances with all of these cardiovascular outcome studies. We've made great advances in terms of treating diabetic retinopathy, but unfortunately we've lagged behind tremendously. Now, this is a picture of the natural history of type 2 diabetes that Dr. Stein and Dr. Selden and I published many years ago, and I think it's still the best sort of depiction of what you can expect in terms of the natural history of people with type 2 diabetes. So let's start at time 0. That's the first time you see the patient. The patient comes in, you measure the serum creatinine, it's 0.8, you measure the BUN, it's 10, you measure the glomerular filtration rate, it's 150, everything looks good. This person has perfectly normal renal function. This person's in trouble. Now, how do I know that? I know that because if I had gone back 3 years earlier, and this actually study was done in Scandinavia, Karl-Erik Mogensen and Hans-Henrik Parving, they looked at people who had strong family history of diabetic kidney disease, and they actually did a kidney biopsy prior to the onset of diabetes. And so if you were to back up 3 years earlier, and you were to measure the creatinine, it would be 1. If you were to measure the GFR, it's 120. What's the difference? The GFR is higher and the creatinine is lower. These people are what we call hyperfiltering. So hyperfiltration in large kidneys, hyperfunctioning kidneys, actually is probably the start of this disease. Now, everything I'm going to take you through on this slide is 100% typical of type 1 diabetes. But you're going to see when we get to type 2 diabetes, things change a little bit. So let's now start to follow this person in time. 3 years after the diagnosis, we're going to measure the creatinine, it's still 0.8. We're going to measure the GFR, it's still 150. Looks perfectly normal. But Dr. Mogensen and Dr. Parving, they actually did a kidney biopsy. Now, I hope you appreciate the art of the glomerulus. Dr. Ralph drew that by hand, okay? I'm not much of an artist, but I can draw glomeruli, okay? And you can see the black schmutzy stuff. That's the mesangial matrix material. That's the glomerulosclerosis that's already started. But you have no idea that that's already going on. Remember yesterday I told you when we talked about SGLT2 inhibitors. SGLT2 inhibitors, if you have heart failure and I treat you with, say, dapagliflozin, I said, you would also expect the benefit of the dapagliflozin if you had a newly diagnosed diabetic patient who didn't have heart failure. Why would you expect that the dapagliflozin is not doing the same beneficial thing at the time you make the diagnosis of diabetes as when the person presents with advanced heart failure? I would say the same thing about the kidney disease. We all know, and I'll show you the data, all of the big studies show if you have advanced kidney disease and I put you on an SGLT2 inhibitor, I can slow the progression of diabetic kidney disease. Well, why do you think it would be any different if you started at time 0 treating the person with one of these SGLT2 inhibitors? The histology has already changed in the kidney. Now, obviously, no one is ever going to do a study where they start treating with placebo versus dapagliflozin at the time of diagnosis and then follow someone for 20 years and not add any other drug. Of course, that's insane. So we're never going to have such a study. But if you understand that the histologic changes are already there at year 3, why wouldn't you think about treating? Okay, this is like heresy. Anytime you have a new idea, of course, it's too expensive. You can't do it. Well, these drugs are soon, in the first quarter of 2025, dapagliflozin goes generic in the United States. So now this drug's going to cost maybe 10 cents a month. It's going to be very, very inexpensive. So it's not unreasonable to think that you might consider treating this person early, even though you're using the drug maybe to lower the A1C, but maybe you're also protecting the kidney. Now, if you continue to follow this person, you can see for 15 years, everything looks pretty good. And then all of a sudden, 15 years later, patient comes, you check the urine, and now you start to see this albumin in the urine. And if you were to check the GFR, you would see the GFR is decreased. From the time you have what we call macroalbuminuria, we've gotten rid of these terms macro and micro, but for the old terminology, if you have more than 300 milligrams of albumin in the urine, that is a very ominous sign. And from that standpoint, until the time you have double your serum creatinine, that's about 5 years. And from the time you double your serum creatinine to the time you're on dialysis, that's another 4 or 5 years. So once you start to see albuminuria in the urine, this is now telling you this person is really at an advanced stage of diabetic kidney disease. And fortunately, we have some very good therapies that if you really are aggressive and intervene, you can make a big difference. Now, fortunately, there is a way of picking up these people at an earlier stage. And this is this concept of microalbuminuria. As I said, in the kidney field, we don't call this macroalbuminuria or microalbuminuria anymore. These are sort of archaic terms, but most of you, this is probably what you were taught. So you can pick up the microalbuminuria, and this means you're excreting between 30 to 300 milligrams of albumin per day. You can pick it up about 5 years earlier. So if you now start at the stage of microalbuminuria, you can make an even greater impact in slowing down the progression of the kidney disease. And that is why on every annual visit, you should be checking not only the GFR, getting the serum creatinine and getting the estimated GFR, but you need to get a urine and check for albuminuria. You should not be checking for proteinuria, okay? So proteinuria contains lots of proteins that are handled by the tubule. So if you had, if you had 300 milligrams of albumin, you'd have about 500 milligrams of protein. But protein is nonspecific. You need to ask for a albumin determination. Now, this is what probably you've all been taught. I'm going to teach you something a little bit different today, okay? In terms of the pathophysiology of type 2 diabetes. And every single thing that's on this slide, which you can read, or you can listen to me, is 100% correct if we're talking about type 1 diabetics. You're going to see it is not correct if we're talking about type 2 diabetes. So let's get started. If you're a type 1 or type 2, you're high glucose. If you have a high glucose, that means you're going to filter more glucose. You have a GFR, but now you have a glucose instead of 80 is 150. You filter more glucose, and in the proximal tubule, at the site of that SGLT2 transporter, you're going to reabsorb more glucose. And with you're going to reabsorb more sodium. So what is the problem now? Less sodium is going to go down to the macula densa cells of the JG apparatus. When the kidney, the distal segments, see less sodium coming down there, they think they're being underperfused. And so there are going to be two stimuli which are generated. The first one is they're going to be a stimulus to the efferent arteriole, the little artery coming out of the kidney, and angiotensin 2 is going to go up, and you're going to become more sensitive to the angiotensin 2. You're going to vasoconstrict. That's going to increase the pressure in the glomerulus. So that's going to increase the GFR, and that's what's caused the hyperfiltration. That's one of the reasons. So that looks good initially, but on a long-term basis, that increase in intraglomerular pressure is going to damage the kidney. The second thing that's going to happen is there's going to signal go to the afferent arteriole, the little artery coming into the kidney, and it's going to say vasodilate. More blood flow is going to go into the kidney, and that's also going to increase the glomerular filtration rate, but it's also going to increase the intraglomerular pressure, okay? So the diabetic kidney is a super filtering kidney. It's also a large kidney. But on a long-term basis, that increase in intraglomerular pressure is going to cause damage. And so this is shown schematically here. So to the right, you can see the afferent arteriole coming in. It breaks up into this glomerular tuft, efferent arteriole coming out. So it turns out, and all of these initial studies were done by Dr. Barry Brenner, a very famous nephrologist in Boston, and he showed that the vasodilation was due to a decrease in adenosine. Adenosine is a powerful vasoconstrictor. If I decrease adenosine, you're going to vasodilate. And then in the efferent arteriole, there's an increase in the angiotensin 2. Now, the standard dogma is that SGLT2 inhibitors work on the afferent arteriole, and the ACEs and the ARBs work on the efferent arteriole. And this is 100% true if you're a type 1 diabetic. It is not true if you're a type 2 diabetic. If you're a type 2 diabetic, we and others have shown that the SGLT2 inhibitor actually vasodilates on the efferent arteriole. From the standpoint of the patient, it really doesn't make any difference. You are going to vasodilate. and you're going to decrease the pressure within the glomerulus, and that, of course, is good. Now, let's now start to look at people with type 2 diabetes. Well, first, many studies have failed to find, particularly in type 2 diabetics, any association between hyperfiltering and diabetic kidney disease, okay? Whereas in type 1s, you almost always see hyperfiltration, and you see big increases in the GFR. You don't see this very commonly in type 2s. And as I said, most of the early studies with the SGLT2 inhibitors were all done with type 1 diabetic patients. So there's kind of I would say, a skewed view of what's going on at the level of the kidney and how these drugs work. So what's the difference between a type 1 patient and a type 2 patient? Well, type 2 diabetic patients, of course, they're much older than type 1. And because they're much older, they have much more atherosclerotic fibrotic changes in their blood vessels, and so they're not nearly as reactive to these vasoactive substances as are type 1 diabetic patients. Moreover, there's an age-related decline in glomerular filtration rate. So actually, when I was a fellow at the National Institutes of Health, it was one of the big studies that I did, and we showed, unfortunately, as we get older, things usually get bad. Same thing happens at the level of the kidney. So if there's an age-related decline in GFR, you start to look at elderly type 2 diabetic patients, you're less likely to see hyperfiltration because they're going to have a lower GFR to start with. Type 2s also have much longer duration of diabetes. Type 1s, they get sick right away. They come to you, you see them. They're usually relatively newly diagnosed. Type 2s, they're usually walking around for 10, 15 years before you see them. So there are a lot of changes that occur in the kidney in type 2s that by the time you see the patient, you don't see that in type 1s. In type 1 patients, there's usually a much greater difference in the level of glycemic control, type 1s being much more poorly controlled than type 2s, okay? Now, what I'm going to do is I'm going to take you through an ominous octet for the kidney, okay? Yesterday, we went through the ominous octet for the pathophysiology of type 2 diabetes. This is all written up in Nature Nephrology Review. In my opinion, it's actually the best article that you can read about the pathophysiology of type 2 diabetes. There are multiple defects. There are at least 8 of them. So at 1 o'clock, we've already talked about this deranged tubular-glomerular feedback. But if we really want to stop diabetic kidney disease, why don't we just control the glucose? And I said this yesterday, okay? Once you develop a GFR that's down in the 30, we spend an enormous amount of time, you'll see, and I'll go through this, we put you on an ACE or an ARB, SGLT inhibitor, epiniterone, et cetera, et cetera, et cetera. But why don't we just control the glucose at the beginning? If your A1C is less than 6.5, you're not going to develop eye, kidney, or nerve complications. And we know this from many studies, and the study that I'm going to use to demonstrate this is the Diabetes Control and Complications trial. So yesterday, I showed you the landmark study for glycemic control in type 2s. That was the United Kingdom Prospective Diabetes Study. The landmark study for type 1 in terms of glycemic control is the Diabetes Control and Complications trial. So these people had an A1C of 9 to start with. It's a huge study. And then half of the people are going to get standard therapy. That's the yellow line. And you can see that over the 10 years of the study, the A1C stayed at 9. I mean, that's pretty barbaric. We would never do this today. But at this time, there was this big debate. If I controlled your glucose, did it make any difference, okay? Many of you are not even old enough. You probably weren't even born when this study was carried out. Probably weren't even aware there was such a debate. Now, the other group got intensive therapy, multiple insulin shots or insulin pump, and you can see the A1C came down to 7, okay? So a big difference in the glycemic control. So we're going to look at 2 groups of people. Let's just focus on the top part of this curve, okay? So these are people who had microalbuminuria who are then going to progress to macroalbuminuria. Okay, so they were between in this particular study, they used 40 milligrams to 300 as the microalbuminuria range, not 30 to 300. And then they're going to see how many people went above 300. So the conventional therapy group is the yellow group, the yellow line, and the intensive treatment group is the green line. And you can see there was a 43% reduction in the development of, quote, macroproteinuria or albuminuria, and the group got intensive therapy. So let's focus on the bottom line. These are people who had no microalbuminuria who are going to progress to microalbuminuria. So the conventional treatment group is in yellow, and the intensive group is in green. And you can see now there's a 58% reduction. So this was the classic study in type 1 diabetic patients that showed that if you aggressively lowered the glucose, you could significantly reduce the likelihood of progression in terms of albuminuria. So good control makes a difference. Next most important thing you can do is control the blood pressure, okay? So this is the one feature that's going to cause the most rapid decline in renal function. And this is an old study carried out by Dr. Parveen, and on the x-axis we're going to look at time, and we're going to look on the y-axis is glomerular filtration rate. So you can see the first part of the curve, which is the open orange circles. He's following the GFR, and you can see it's coming down quite rapidly. So then 20 months later, he says, I'm going to start treating the people, okay? And what were the drugs that he used? He used guanethidine, okay? How many people in this room have ever used guanethidine to treat hypertension, other than me? Okay? You don't even know what the hell it is, right? It's ganglionic blocker, okay? How many of you use reserpine to treat hypertension? 2 of us. How many of you have ever used mercurial diuretics for diuresis? Put your hand up. Maybe 2 or 3 people. So these truly were barbaric medicines. But that's what was used in this study. And look at the change in the slope of decline, okay? Using medicines that were used long before you were even born. Look at the impressive change. So meticulous control of blood pressure is critical. And meticulous control of blood pressure is not 130/90. It's 120/80, as long as you don't make the person symptomatic from hypotension. Of course, you've got to use some common sense. Now, because they've been around forever and they're very well established, and we have a number of trials, the ACEs and the ARBs, and it really doesn't make any difference which one you want to use, they're the preferred choice because lower blood pressure. Because not only they lower your blood pressure, remember the efferent arterial constriction that's causing the increase in glomerular pressure? I'm going to vasodilate and decrease the intraglomerular pressure. So you're getting sort of a double benefit. I'm lowering the blood pressure, that's good, and then I'm also decreasing the intraglomerular pressure. Next on the list of things you have to think about is the tubular growth factor hypothesis. So if you look at the diabetic kidney is very large. And the first thing that hypertrophies actually, interestingly, are the tubules and the glomeruli. And they're very, very large, long before there's any protein in the urine. So large kidneys, okay, giant filtering kidneys are characteristic of people with type 2 diabetes. And it turns out that the tubules secrete a variety of growth factors that cause the glomerulus to hypertrophy. So why is that important, okay? When the glomerulus hypertrophies, the pressure within the glomerulus is proportional to the radius of the glomerulus, is the law of Laplace. So if you have tubular growth factors that tell the glomerulus to hypertrophy, okay, by definition, there's going to be an increase in intraglomerular pressure. And in animal studies, you can actually block the tubular hypertrophy with ornithine decarboxylase. And if you do that, you will completely block the glomerular hypertrophy. And if you do that, you prevent diabetic kidney disease. It's very interesting. This is an old study, but no pharmaceutical company actually has followed up on this approach of treating people with diabetic kidney disease, even though I've given this lecture many times and pharmaceutical people have been in the audience. they don't seem to get the message that this is something that would be worthwhile following up on. Next on the list is the podocyte. So you all went through your histology course. You all remember who the podocyte is, but today you probably have no idea who the podocyte is, okay? So the podocyte are the cells that sit on the glomerular basement membrane, and with the foot processes, prevent albumin from getting in to the glomerular Bowman space in the glomerular tuft. Well, why is that important? Albumin is very toxic to the kidney. So if albumin escapes into the glomerulus, that's promoting glomerulosclerosis, and that's also causing severe interstitial nephritis when the albumin gets down into the tubules. People have been looking for insulin resistance in the kidney forever. It's the one organ in which no one has been able to show that there is any insulin resistance there. It's the podocyte. So how do we know that? If you take animal models and you do the insulin receptor knockout in the podocyte, only in the podocyte, knock out the insulin receptor. I've made the podocyte insulin resistant. You develop florid diabetic kidney disease. So the podocyte, in my opinion, is the site of insulin resistance in the kidney to contributing to the progression of diabetic kidney disease. And there are very, very good studies that have shown that if you can decrease the amount of albumin that's in the urine, you can markedly decrease the decline in GFR. So for every 30% decrease in albuminuria, you reduce the risk of developing end-stage kidney disease by about 30%. So getting rid of the protein in the urine is very important. We all think the protein or the albumin is a marker of kidney disease, and it is. But you need to understand that it's also one of the factors that's causing the progression of the kidney disease, and that's not very well appreciated. Next on the list is that we need to think about is hypoxia. Why? You filter, remember that enormous increase in GFR, very high glucose, you're filtering a lot of glucose. All of that glucose is reabsorbed in the proximal tubule by the SGLT2 transporter. You cannot keep sodium in the cell. The main intracellular electrolyte is potassium. So you have to get the sodium pumped out of the proximal tubule. That is done by the sodium-potassium ATPase pump, and that is energy requiring. Now, even though there's an increase in renal blood flow, and therefore more oxygen being delivered to the kidney, that increase in oxygen delivery does not suffice to meet the increased need of that pump. So the kidney is itself very, very ischemic. In addition, a lot more of that sodium is going to get down to the loop of Henle, and that has to be reabsorbed there, and that's also very energy requiring. So using bold MRI, many people have shown that the kidney is ischemic, and when the kidney becomes ischemic, it releases a whole host of growth factors, fibrotic factors, et cetera. So this mismatch between the increase in oxygen demand and oxygen delivery is a very important cause of hypoxia and diabetic kidney disease. Next on the list is obesity or lipotoxicity. A lot of people want to take credit for the term lipotoxicity, but there's only one person who developed that term, and that was me some 35 years ago, okay? Now, lipotoxicity, you put it in your heart, this is HFpEF. You put it in your liver, this is NASH. You put it in your arteries, this is your heart attack. You put it in your kidney, and this is diabetic kidney disease. And this is not appreciated. If I had to estimate what percentage of diabetic kidney disease is due to the glucose and how much is due to the lipid, I would say about 1/3 of the diabetic kidney disease is due to lipotoxicity, okay? Now, if you look at obese individuals, and there are many, many studies similar to the one that I'm going to show you here. This comes from a very large actuarial database of over 8 million individuals, where we're going to look at the risk of developing end-stage kidney disease on the y-axis, plotted against the BMI. So you can see as you go from a BMI of 25 up to 40, the risk of developing diabetic, it's actually fatty kidney disease, these are not diabetics, goes up 7-fold. So this is a well-established disease. But primary care docs actually, I might even say endocrinologists, are not aware of the fact that obesity is in fact an important cause of kidney disease. So if you were to do a biopsy in an obese, non-diabetic individual, that is shown in the upper left, panel A. Upper right is the lean person. These are taken at the same magnification. And what you can see immediately is that the obese glomerulus is twice the size of the lean. So this is marked hypertrophy. Once you have this expanded kidney, the pressure in the glomerulus is already increased, as I told you before. Now, in figure C in the bottom, if you can see the arrow in, let me see here. Yeah, if you can see this arrow down here in the bottom right, this is focal glomerulosclerosis and podocytes being attacked. And then this is glomerular basement membrane thickening with lipid deposit in the glomerular basement membrane. If you now do EM, okay, these are podocytes, and I think it's very clear. You can see these lipid droplets in the podocyte. This is a mesangial cell over here, more lipid droplets than the tubule cells. So lipid in the kidney is a very important cause. And I'm quite certain, and Dr. Abdulghani and I talk about this all the time, I tried to get Takeda Pharmaceuticals to do the study with pioglitazone. Pioglitazone is great at mobilizing fat out of the kidney. Every animal model that's been looked at of diabetic kidney disease is cured by pioglitazone. The GLP-1 receptor agonist is the best drugs in the world for getting fat out of everywhere. They're going to be very effective, and I'll show you in a second that that's true, and also preventing diabetic kidney disease. So the last one that we have to worry about are genetics. As I say, if you choose your parents unwisely, you're screwed. You can't go back and re-choose them again, okay? And if you have a patient, a newly diagnosed diabetic, and you would like to get some insight as to whether they're going to be predisposed to develop diabetic kidney disease, just ask them about their family history. Mother, father, they alive, dead? Oh, yeah, my mother, yeah, she had diabetes. Yeah, she was on dialysis. Any brothers and sisters? Oh, yeah, I have a sister. Oh, yeah, she's looking after by the nephrologist. She's probably told she's going to have to go on dialysis. So there clearly are very strong genes that are playing a role here and yet to be identified. So this is a study from the Joslin Clinic many, many years ago. So we're going to take the siblings of a proband who have diabetic nephropathy. And then we're going to ask, look, we're going to ask about your other sisters, mothers, brothers, etc. You can see 40% of the family members have end-stage renal disease. 40% already have albuminuria, and only 10 to 20% are free of kidney disease. Now, you take the probands who have no family history of diabetes, okay, who they present without diabetic nephropathy, and you ask their family history, you see either the disease runs in family or doesn't run in families. What the genes are, there was a big study carried out by the National Institutes of Health called the FIND study. We are going to define the genes that cause diabetic kidney disease. You know what they discovered? You know what that is? Zero. Not a single gene, okay? So we still don't know what the genetic etiology of this disease is. So now what about treatment, okay? We talked about combination treatment, not using drugs alone. If you've got 8 problems attacking the kidney, why do you think one drug is going to correct 8 problems? And those 8 problems I showed you are really very, very diverse, okay? So we have ACEs and ARBs. We have SGLT2 inhibitors, a whole bunch of them. We have the nonsteroidal mineralocorticoid receptor antagonist, feninerone, and most recently we have the GLP-1 receptor agonist. So let's start with the SGLT2 inhibitors. There's been many, many big studies. I'm just going to show you one that basically the results are all the same. So this is DAPA-CKD, big study, 4,300 individuals. You can get into DAPA-CKD because you had a GFR between 25 and 75. So you could ask, well, if you have a GFR of 75, what are you going to put someone in this study for? Because you could have a lot of protein, albumin, in the urine. So you might have 1,000 milligrams of albumin, but relatively normal GFR. You could get into the study. The other thing that's important is 2/3 of the people were diabetic, 1/3 are not diabetic. And I'm going to show you the results didn't make any difference whether you're diabetic or non-diabetic. The study was supposed to go on for like 4 years, but they cut it short. The Data Safety Monitoring Board said that the results are so positive, we cut it short at 2.4 years. And in all of these studies, there's a very similar endpoint. 50% decline in GFR, or you end up with end-stage kidney disease, means you're on dialysis or transplantation, or you have death due to renal disease. So you can see here that these curves start to separate within 4 to 6 months. Hazard ratio is 0.61. 39% decrease in that composite endpoint, and the curves continue to separate with time. Number needed to treat, we talked about that yesterday, 18. That's a very good number needed to treat. So we can look at some of the individual endpoints. So from left to right, worsening renal functioning or death from kidney failure, hazard ratio is 0.56, very impressive. In the middle is hospitalization for heart failure and cardiovascular death. I told you kidney disease and heart failure go hand in hand. Hazard ratio 0.71. All-cause mortality, the definitive endpoint, 0.69. And all of these SGLT2 inhibitors have basically shown the same thing. You know, each company wants you to think their drug is better than the other one, but in my opinion, they're all basically the same. So this is another important point that was made by Dr. George Bakris, the late Dr. George Bakris, who recently passed away, is a very good friend of mine. And he made this point in the year 2000 with the ACEs and the ARBs. And the same thing applies to the SGLT2 inhibitors. So here, we're going to look at time in terms of months on the x-axis, and we're going to look at the change in the GFR on the y-axis. And you can see when I put you on the dapagliflozin, you can see orange, the GFR drops, okay? And primary care doc, and the creatinine will go up a little bit. Primary care docs get nervous when they see this, and they may stop the SGLT2 inhibitor. You should never do that. The fact that you see that little drop means you decrease the intraglomerular pressure. And when you decrease the intraglomerular pressure, you're going to get a little drop in GFR, okay? But then you can see if you continue to follow, the orange line plateaus off, the placebo keeps going down. So this little drop here, we use the 30% rule. This is what Dr. Bakris taught us, that if the GFR drops by less than 30% or the creatinine goes up by less than 30%, do not worry. That will almost never happen. And in fact, I never ever check the serum creatinine or the GFR after I start someone on an SGLT2 inhibitor, because all that's going to do is make me nervous. And I don't want to be nervous. I got other problems to deal with, okay? So if you want to check it a couple of weeks, you can. Very rarely, I would say I've virtually never seen it, but this is the 30% rule. If you're wondering whether you should check it or not, I would say probably don't check it. Now, these are the data, patients with type 2 diabetes to the left, patients without type 2 diabetes to the right. Hazard ratio for that combined endpoint is 0.64 versus 0.50. These are basically the same. So whether you have lupus nephritis, IgA nephropathy, whatever, or whether you have diabetic nephropathy, you're going to get the same benefit of being on dapagliflozin. And I would say whether you're on empagliflozin, canagliflozin, et cetera, these drugs are all very, very good drugs. Dr. Abdulghani mentioned this yesterday. There are a lot of people in this study who didn't have diabetes. And so over the time, you could follow these people up and you could see whether they developed diabetes or not. And so you can see here the cumulative incidence of new onset diabetes with dapagliflozin versus placebo. There's a significant decrease of about 70%, okay? Now, here are the SGLT2 inhibitors, okay? How many can you count? A lot of them, right? Here's the pathophysiology. Now, if you correcting 6 of the problems, that's probably going to be a pretty good drug for treating diabetic kidney disease. So all of these studies I didn't mention this, that were carried out with SGLT2 inhibitors, you had to be on an ACE or an ARB. So that's going to be first-line therapy. How long do you wait to start the SGLT2 inhibitor? 2 weeks, 4 weeks. You don't have to wait any longer than that, okay? This is not stepwise approach. We generally don't recommend you start both at the same time. But there's no reason to wait more than 2 to 4 weeks, okay? These drugs are not going to have some causative negative interaction. So start quickly. Now, who's the new kid on the block? The new kid on the block is finerenone, Canendria, okay? This is a non-steroidal mineralocorticoid receptor antagonist. It does not lower your glucose. Dapagliflozin, canagliflozin, empagliflozin lower your glucose. This is not a glucose-lowering drug. This is a drug that's used to protect your kidney. It's also a drug that's used to protect your heart. It's very good for treating heart failure, okay? So if you look to the left, this is the renal composite outcome, and they were both diabetics and non-diabetics, and they equally benefited. And it's end-stage renal disease, meaning dialysis, transplantation, a GFR that's less than 15, that stays less than 15, and you can see the hazard ratio here is what, 0.82, and the key secondary outcome, cardiovascular outcomes, cardiovascular mortality, heart failure. Just as spironolactone is a good drug for preventing heart failure, this is a very good drug for preventing heart failure. We have a cardiologist running the meeting today. I asked my cardiologist, Dr. Anderson, do you ever use this drug? And he says, no. And I said, why? And he says, because spironolactone costs 1 cent per month, and this drug costs like $500 a month. We'll see what you think later. They're supposed to get less hyperkalemia with this drug, but there was a recent meta-analysis by Dr. McMurray from Scotland, a very famous cardiologist, and in this meta-analysis, he actually showed, and when you compare spironolactone versus finerenone, there was no difference in the incidence of hyperkalemia. You can imagine that the manufacturers there hated that meta-analysis because lack of hypokalemia is supposed to be one of the selling points. Okay, so you saw the big 8 factors that initiate the disease. But now there are a lot of downstream mediators, and I've listed 6 that are pretty well established. How does finerenone work? Finerenone works on inhibiting inflammation, fibrosis, and oxidative stress. So it works in a very different way than do the SGLT2 inhibitors or the ACEs or the ARBs. So you can get a completely additive effect in terms of renal protection. So we have, at our institution, instituted a renal care pathway. So when the physicians see the patient, and it's a diabetic patient, the pathway automatically comes up. And it says, have you gotten an albumin excretion? No, okay? That doctor cannot sign out the case that day. It's a very effective way. Have you gotten a creatinine clearance? No, you cannot sign out. So if you want to go home at night, you better order the urine albumin and the creatinine. When you come back now for clinic, the albumin and the creatinine is going to be there. And it's going to say, have you got the person on an ACE or an ARB? And if you don't, you're not going home that day. You must start the ACE and the ARB. And then when the person comes back, it's going to say, did you repeat the albumin and the creatinine clearance? Nope. Well, you better repeat it or you're not going home. And then when it comes back, it says you need to add the SGLT2 inhibitor, and then you must add the finerenone. So we have taken this out of the control of the doctor, okay? If you want to go home and see your wife, well, maybe that's a good reason you don't want to go home and see your wife. Don't sign out, okay? But if you want to go home and see your wife and your kids, it forces you to follow this. Remember I told you 10% of people with chronic kidney disease are undiagnosed in the United States. That's totally unacceptable, because we have treatments. So docs are docs, and they don't tend to get these measurements, and unless in the computer system you actually force them to follow the renal care pathway. They oftentimes don't do it, okay? So finerenone is a very, very good drug, okay? We have ACEs, ARBs, SGLT2 inhibitors. Now here's the new kid on the block, GLP-1 receptor agonist. This is the FLOW study with semaglutide, okay? A very, very large study, 3,500 individuals. Again, this study done in people with type 2 diabetes, and it's semaglutide versus placebo, and it's added on to an SGLT2 inhibitor, an ACE and an ARB, and you can see hazard ratio is 0.76. This is pretty recent. It's under review by the Food and Drug Administration. I would say it's 100% sure it's going to get approved. So basically now, we have 4 choices, and you don't have to wait. You know, every 2 to 4 weeks, you can be progressively adding a new drug. Finerenone is quite expensive. We already talked about these drugs. They're about $1,000 a month, semaglutide. So the big problem is not efficacy. The big problem, of course, is expense, okay? Now, SGLT2 inhibitors in cardiovascular disease. I told you that if you have someone who has chronic kidney disease, okay, they're still 5 times more likely to die of a cardiovascular event than they are of their chronic kidney disease. They have a GFR of 20. You'll think they're more likely to be up on dialysis and die. Wrong. They're 5 times more likely to die of a cardiovascular event. That means they must have a LDL cholesterol. We can have some discussion. In my opinion, it should be less than 50. They should have a normal lipid profile. They should have a good blood pressure. Whether they should be on aspirin or platelet therapy, that's somewhat conjectural. But you need to make sure all the risk factors are very well controlled. And I showed this slide yesterday. These are the GLP-1 studies in terms of cardiovascular disease: liraglutide, leader, semaglutide, sustained 6, exenatide, dulaglutide, hazard ratio all about 0.8, all showing cardiovascular benefit. I also showed these 2 slides yesterday, again, in terms of combination therapy. This is duration 8, basically a cardiovascular outcome study. I'm going to show you the A1C, and then I'm going to show you the cardiovascular events. So dapagliflozin is to the right, low is the A1C 1. Exenatide is an old guy. You know, Muhammad and I used this 20 years ago. No one uses this anymore, okay? 1.3, you put the 2 together, I dropped the A1C by 1.7, okay? Now, I invented completely the SGLT2 inhibitors and didn't patent it, but we invented it as a treatment for diabetes, lowering the A1C. But I would have to say that the real benefit of the SGLT2 inhibitors are their renal protection and their cardiovascular protection. So here now, we're going to compare dapagliflozin to the combination of DAPA and EMPA, or EMPA exended versus the 2. You have a 24% less likely chance of having a MACE endpoint if you're on 2 drugs compared to 1 alone. You are 29% less likely to have a myocardial infarction if you're on 2 drugs, and you are 32% less likely to die if you're on 2 drugs. So here we got now dapagliflozin, it's great for your kidney, great for your heart. We have exenatide, which is great for your heart. Whether all GLP-1 receptors will work like semaglutide to protect your kidney, I think is unknown. And I have a feeling that the older GLP-1s may not be so renal protective. We'll probably never see a study done because no one's going to go back with the newer ones. So now, these are the updated guidelines, and I showed you yesterday from the American and European Diabetes Association. First-line therapy, no longer we see metformin, finally, okay? Some sanity at the American Diabetes Association. Transient sanity, okay? If you have atherosclerotic cardiovascular disease, you're going to put the person on a GLP-1, SGLT2, or as I think, insinuated, probably put them on both together. If you have heart failure, SGLT2, okay? If you have renal disease, it's going to be an SGLT2 inhibitor, okay? So the conclusion, I think, is pretty clear. If you got multiple pathophysiologic disturbances, okay, and you really want to slow down the progression of diabetic kidney disease, you better start to think about multiple drugs. and getting the person on the multiple drugs as quickly as possible. For sure, you should be doing triple therapy, okay? The question mark for quadruple therapy is only because the flow study with semaglutide, it's not yet been approved by the FDA, okay? But the study is very positive. I would be shocked if it's not approved by the FDA. So that means you ought to be thinking about quadruple therapy. Here's the quadruple therapy, and the sooner you start, okay, the better off you're going to be in terms of your patient care. So.